It's like a constant war, and you wanna settle that scar, but you're bruised and beaten, and you feel defeated. This goes out to the heaviest heart. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out of the dark into the light. It's not over, hope is rising. Never give in, never give up. It's not over. Yeah, whoa. Yeah, whoa. Oh, game, set, match. Time to put it in your past. Oh, feel the winter leaving. It's redemption season. Long live the young and high. Cheers to a brand new start. We're revived and breathing to live a life of freedom. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out of the dark into the light. It's not over, hope is rising. Never give in, never give up. It's not over. Yeah, whoa. Yeah, and life is a race we run, so run till the race is won. Don't you ever give up, no, never give up. Life is a race we run, so run till the race is won. Don't you ever give up, you will never give up. To everyone who's hit their limit, and even when you think you're finished. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out of the dark into the light. It's not over, hope is rising. Never give in, never give up. It's not over. Yeah, whoa. Yeah, whoa. Yeah, whoa. Yeah, whoa. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out of the dark into the light. It's not over, hope is rising. Never give in, never give up. It's not over. Yeah, whoa. Yeah, whoa. Oh, to everyone who's hit their limit, and even when you think you're finished. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out of the dark into the light. It's not over, hope is rising. Never give in, never give up. It's not over. Yeah, whoa. Yeah, whoa. Yeah, whoa. Yeah, whoa. Yeah, whoa. Yeah, whoa.
Welcome everybody to this Young Epilepsy Section webinar series. Today we have the pleasure to present Professor Reetta Kälviäinen, who is going to talk to us about refractory and superrefractory status epilepticus. Professor Reetta Kälviäinen is Professor and Chair of Neurology in the University of Eastern Finland and the Director of the Kuopio Epilepsy Centre in the Kuopio University Hospital. Her special research interest is clinical epileptology, including identifying biomarkers of seizure activity, epileptogenesis, progression and drug resistancy in cohorts of newly diagnosed and drug-resistant chronic patients. These aspects of scientific projects are combined with therapeutic neuropharmacological interventions. She serves in the steering group of the European Reference Network for Rare and Complex Epilepsies, EpiCare, of which Kuopio Epilepsy Centre is a member, and is a member of the management group of the Epilepsy Scientific Panel of the European Academy of Neurology. The learning objectives for today's webinar are the following: to appropriately diagnose all types of convulsive status epilepticus, including differential diagnosis, to appropriately diagnose all types of non-convulsive status epilepticus, including EEG interpretations, including differential diagnosis, appropriately manage all types of convulsive status epilepticus, including EEG monitoring of treatment effect, and appropriately manage all types of non-convulsive status epilepticus, including EEG monitoring of treatment effect. Professor Kälviäinen, welcome, and thank you for accepting our invitation.
Thank you very much. It's really my pleasure to be here this evening. It's now quite late in Finland, in Kuopio, in the Lakeland area, in central part of Finland. So where we are in the middle of nowhere, some could say, but we think that we are somewhere where we know where we are. And this is Kuopio. In the eastern part of Finland, in the Nordic countries nearby the Russian border in northern Europe. So now you know where we are. And I would like to start my presentation about refractory and superrefractory status epilepticus. But first, these are my disclosures. I would like to mention that I have been now the past president of the Finnish ILAE chapter for 10 days. And as my last action in Finland, I in fact wanted to promote the Yes ILAE activities in Finland. And we have now a formal decision to start the activities also in Finland. I'm really happy about this. And I really look forward also having all these activities in our own country. But coming back to status epilepticus and especially refractory and superrefractory status epilepticus, this is the outline of my talk. I will talk about a little bit about the definitions, pathophysiology, epidemiology, prognostic factors, outcome, active treatment, then pitfalls in the treatment, palliative treatment, and some conclusions. So this is the familiar staged definitions of status epilepticus. And you can see the stage 3 refractory status epilepticus, which is the situation where status epilepticus continues despite of the stage 1 or 2 treatments. And if this situation continues despite of the stage 3 treatments with anesthetics over 24 hours, then we think, we say that this is super refractory status epilepticus, and we are in the stage 4. This is a very dynamic process, and in fact, we need to really think about what happens to the patient that starts to have convulsive status epilepticus, what we are today mostly talking about is a comatose non-convulsive status, where there is already an electromechanical dissociation, where there either can be some myoclonic jerks, but basically usually the convulsive jerks have already stopped. There's an only comatose patient that can be misinterpreted as having already stopped having the status epilepticus, but the electronical discharges continue or have changed also, and it's very important to notice the situation. There are systemic and brain metabolism changes, and if you are able to see imaging results, there is vasogenic and cytotoxic edema, and it's very important at this phase to start to prevent and reverse the brain damage and the long-term consequences. But we are really not talking about convulsive status. We are talking about a patient who is not convulsing anymore, and it's important to notice this situation. What pathophysiologically is happening when we turn from established status epilepticus to refractory and superrefractory status? Already within the minutes when status epilepticus starts, there is receptor trafficking where kappa receptors are experiencing endocytosis, and there's NMDA receptor upregulation. So first, the status is kappa responsive. There's an inhibition failure, but this is still, the situation is kappa receptor responsive. But very soon, when we are facing the established status epilepticus, and especially the refractory phase, the situation turns to kappa receptor unresponsive phase. And there's also at the same time excess of excitation and an excitotoxic cell damage is happening if we are not going to prevent it. There's rapid synaptic plasticity, kappa receptor composition changes, and many altered gene expression phenomena happen, like multi-drug efflux transporters, drug resistance proteins, and drug target alterations are happening. One of the key issues which have been lately discovered is that so-called reactive oxygen species are responsible or contribute to the both to the excitotoxic neuronal cell damage during and following the status epilepticus. And of course, we have for a long time already been trying to seek therapies for this cell damage. Antioxidant therapy is futile because of the poor CNS penetration. And there is now some evidence from animal studies that promoting the production of endogenous antioxidants through activation of transcription factor number 2 NRF2 could be neuroprotectant, and also seems to decrease frequency of spontaneous seizures following the status epilepticus. So there's this important excitotoxic cell damage that we need to prevent. And then in the beginning of the status and lasting through the refractory and superrefractory phase, there is this receptor trafficking, which seems to contribute to the loss of GABAergic drug efficacy. There is already a very classic experiment that shows that in a rat model of status epilepticus, we need 10-fold greater dose of diazepam to control the seizures that have lasted 45 minutes compared to those lasting 10 minutes. And it's really, this is also known in human that benzos help in the beginning, but they don't anymore control the seizures, or the efficacy is not so good in the refractory phase. And we need to take into account this receptor trafficking problem. So how often do we have refractory status epilepticus or super refractory status epilepticus? This is something that we have been looking at the population-based level in Kuopio, in our area, and also in Finland, in our population of 5.6 million inhabitants. In our area in Eastern Finland, currently about 300 or 350 emergency medical system calls are done per 100,000 inhabitants annually because of seizures. So somebody calls to the 112, to the EMS number. The problem may be solved by the phone call or by the EMS personnel, by the ambulance going to see the patient, and they can already help the patient. And only 80 patients per 100,000 annually come to the emergency room. And these are those patients that we then think that really have the early status epilepticus. So status epilepticus that really lasts over 5 minutes, 5 to 30 minutes. So 80 per 100,000. Then second stage is about the incidence of second stage. Established status epilepticus is about 10 to 20 per 100,000, and refractory status epilepticus third stage, we see 3 patients per 100,000 inhabitants per year annually. And only one of them, 1 per 100,000 inhabitants annually, seems to be super refractory. So this is something that we have looked at the population-based level in fact in 2 series of studies. And this is the similar studies, that similar numbers that have also been found in Salzburg area by Professor Trinka. And there is data also from children that the incidence is lower in children, except for very young children, where in infants the incidence is again higher. So what is the outcome of refractory and super refractory status epilepticus? The term super refractory convulsive status epilepticus was first brought up by Simon Chauven in 2011 and 2012. And he, together with Monica Felici, they looked back all the literature, and the outcome at that point was that for refractory status epilepticus, mortality was about 35%. We looked year 2017, all the case reports between 2011, 2017, and could divide those case reports between the new term super refractory status epilepticus and refractory status epilepticus, and could then differentiate that the mortality was really in fact higher, of course, in super refractory status epilepticus being 55%, whereas in refractory status epilepticus 41%, and only about 20% were functionally covered to baseline after super-refractory status epilepticus in the literature at that point. There are now new case series reported more and more, which is of course great. We looked also in our series the mortality, and in our population-based series in Finland, which is really population-based in that way that we have in Finland a Finnish intensive care consortium, which really gathers data from all the intensive care units from Finland prospectively. And we could look at the intensive care unit treated refractory and super-refractory status epilepticus cases and their mortality. So this is now intensive care unit treated patients, not all cases, not all the refractory cases, but only those who were admitted to the intensive care unit. And with these patients, we could then prospectively look 1 year mortality rate, which was for refractory status epilepticus 22%. This is now adults, meaning age of over 16 years. And then 1 year mortality rate for super-refractory status epilepticus was 36%. I think these are quite realistic, modern figures for intensive care unit in a setting where really also palliative care is given and not all patients are admitted to the intensive care unit. I will come back to this later. What are then the predictors of 1 year mortality in these intensive care unit treated patients? It's really clear that higher age, but especially poorer pre-morbid functional performance are the predictors of the mortality. You can see with the black piles behind that those patients, regardless of the age, that were non-independent in their activities of daily living, had a very high mortality from 40% to 60%. And especially those with higher age and who were non-independent before or had poorer pre-morbid functional performance before admission to the ICU, they really had a poor outcome regarding the mortality. Whereas then if you are young and if you are independent in your activities of daily living, the mortality is low, being about 5%. Our hospital mortality overall was quite low in this series. So how can we then predict what is happening? There are some prognostic scores for status epilepticus. There is STESS score, EMSA score, a modified STESS score, and so-called END-IT score. For example, the STESS score, the status epilepticus severity score, it takes into account consciousness, the worst seizure type, age of the patient, and history of previous seizures, that is, whether the patient has epilepsy or not. That's a quite simple score, and unfortunately, that doesn't predict quite well the long-term outcome of the patient. The EMSA score is somewhat more complex. It's not so easy to use, but it has more prognostic value. It takes into account etiology, comorbidities, age of the patient, and then EEG, which makes it demanding to use, but gives it more prognostic value. So EMSE also predicts some functional outcome after refractory status epilepticus. All the EEG prognostication is still in development, and of course EEG always needs to be also interpreted in the context of clinical situations. So you cannot use EEG alone, and also the driver of many of the EEG patterns is the etiology. So this is a very complicated situation. What I think that will happen and should happen during the years that you will work with these problems and challenges is that we would need multimodal neuroprognostication. So we should use big data and machine learning techniques and integrate all the clinical, genetic, epigenetic, metabolic, inflammatory, structural biomarkers into sort of matrices that would then allow more accurate and personalized prognosis. We are not going to be able to do it ourselves. We need also machines to do it for us. At the moment, before this big data approach is done, so what we have at the moment we can look the consciousness. As I said, these are comatose patients with non-convulsive status. So we evaluate the classical coma scale, or whatever the way is how you evaluate the coma states, the age of the patient. You evaluate the etiology, the comorbidities, and the premorbid functional states. And with this data, you need to evaluate the prognosis. At the moment, we don't have better than that. So coming back to the numbers, as I said, I was talking about ICU-treated refractory status epilepticus and the prognostic of the outcome of that. That is the way that we usually have been thinking about the situation. We have a refractory status epilepticus, and those patients are treated by anesthetics in the ICU. That is our guidelines, and that is how we are taught to think about this situation. But the whole picture is not like that. We should start to think about the whole picture. And in fact, this is how we at the moment divide our patients. We divide them to those who we treat actively in the refractory states with ICU treatment, and those that we treat palliatively. And if we prospectively look at these figures, we can see that, as I said, we have about 3 per 100,000 patients, inhabitants per year, patients that have refractory status epilepticus that is treated in the ICU. And we have about 2 patients per 100,000 inhabitants that refractory status epilepticus that we are treating palliatively. So that is also a very important group of patients. But first, I'm now going to talk about this active arm. So how we treat patient actively. And this is familiar. This is the guidelines that we have. After the second phase and second stage, we move into the stage 3, where we have the anesthetics. We either choose propofol or we can use also midazolam together with propofol. Sometimes we used pentobarbital or thiopental, depending what is the situation, what is the age of the patient, and sometimes these are also used in a staged way, so that some centers used first during the first trial propofol, and if the first propofol anesthesia doesn't help, then in the first super-refractory stage, they then, as we also very often we have so far used thiopental as the second anesthetic and the first anesthetic in the super-refractory phase. Nowadays, as I'm going to say, ketamine is coming more and more often used anesthetic, and also its place is going to be moved perhaps towards being used more earlier in this staged approach. And then there are these other treatments, additional treatments like ketogenic diet, immunomodulation, hypothermia, neuromodulation treatments that can be also then added to the treatment if the refractory status continues and if it's going to be super refractory. So I was especially asked to talk about the new treatments or newer treatments, and ketamine perhaps is one of those that as I said, the place of and use of ketamine is currently changing. It's a potent NMDA antagonist, unlike the other anesthetics, and therefore it's an attractive choice for a number of reasons. It's good because, as I said, there is this receptor trafficking, and it's not only that the GABAergic receptors are decreasing, there's also an increased intensity of NMDA receptors on the cell surface. We would need NMDA antagonist-like activity in this case. And the cell death in status epilepticus is mediated by glutaminergic processes. So therefore, ketamine might have also neuroprotective properties. And it doesn't depress respiration or cause cardiac depression. So there is also hope that we could use this even earlier than in the third phase. And it might be also anti-inflammatory, and that's also, of course, very good feature of ketamine. At the moment, we don't have yet any randomized controlled trials, and the published experience is only some open case reports or case series or case reports, and it has some clear advantages over conventional anesthetics, and it doesn't necessarily require intubation, and therefore it might even also have some role in non-convulsive status epilepticus, I mean non-comatose, non-convulsive status epilepticus. Something that has to be remembered is that it might not be burst suppression that we should aim with ketamine, but diffuse slowing and beta activity in EEG. And then, unfortunately, common side effect of ketamine might be hallucination, and that might be problematic, especially when we are weaning off ketamine and trying to follow up whether there are any symptoms of the status epilepticus Other adverse effects are hypersalivation, dysphoria, nausea, and vomiting. There are now a couple of trials ongoing. In fact, I could find 2. So first of them is for adults. This trial is enrolling patients over 18 years and comparing ketamine against standard anti-seizure medication treatment, benzodiazepines, partnerapes, and propofol in controlling refractory status epilepticus. And the primary outcome will be average time taken to initiate burst suppression. So they are using burst suppression as endpoint. And then there is another Italian study, which is enrolling children. And this is again also then comparing ketamine with high doses of midazolam, thiopentone, and propofol in the treatment of convulsive refractory status epilepticus in children. And they also have a primary outcome will be the number of participants with resolution of convulsive refractory status epilepticus by EEG criteria. They had also other EEG criteria than only burst suppression. This is very interesting trial, and hopefully these both trials will get us more data about use of ketamine, which seems to be quite promising in the treatment of refractory status epilepticus, and it's used more often and more earlier than it used to be. One other thing that we need to always remember, and our guidelines unfortunately fail to emphasize this, and I see often problems regarding this issue. When we start anesthetics in the refractory and super refractory status epilepticus, our guidelines fail to emphasize that we need to start also or continue the second line anti-seizure medications and build up a very effective combination of drug treatment with different mechanisms of action. So we need to have there at least 2 or sometimes 3 different kind of medications, because when we are weaning off the anesthetics, then we need to have something to keep the patient seizure free. And this is something that unfortunately happens every now and then, that people forget to build up this basic anti-seizure medication to the patient before they wean off the anesthetics. And what we can use, we should stick mostly to those treatments that can be still used intravenously, because then we can really make sure that the levels are adequate. Some of the treatments can also be used orally via nasogastric tube, but then we cannot always be sure that the levels will be adequate. Clobazam, topiramate, and perampanel are those treatments. Perampanel very often nowadays used because of the AMPA antagonism, which is very important mechanism. Fortunately, IV formulation should be available for perampanel in future. And now we only have the oral formulation. But from these medications, you need to build up the background medication before weaning the anesthesia. When we are then stopping or weaning the anesthesia, it's a very complicated issue, and the complex predictors tell us again whether we are going to be successful or not. And this is a very excellent study where the investigators by Daniel Lowenstein and his study group, they tried to evaluate whether duration of therapeutic coma will influence the outcome of refractory status epilepticus. They partly succeeded in their goal, but what I think they better could show us is how complex this situation is, and how complex interaction there are between all the confounders and all the variables that influence to the outcome. And therefore, we really, as I said, need these machine learning techniques and big data analysis to really build up models that will tell us better the prediction of each patient. This is not something that our own brains can really analyze. But in any case, these are very complex situations, and not a single variable is influencing the outcome and the mortality of the patient. One of the known factors that influences the outcome is, of course, etiology. And while we are treating actively the patient with the anesthesia and with the anti-seizure medication and building the background medication, we always also need to, at the same time, work up with and try to find what is the etiology of the situation, why the patient got the status epilepticus. And half of the patients do have epilepsy, and for them, the reason might be that there is non-compliance, or there has been some mistake in the anti-epileptic or anti-seizure medication use, or some other situation what causes the epilepsy to be out of control, or there are some epilepsies, syndromes where there are recurrent status epilepticus situations. So this is another story, and very often these patients with epilepsy who experience status epilepticus situations, they can be really amazingly helped by treating actively the epilepsy, which is very important. And if a patient comes with status epilepticus, has an epilepsy in the background, they need to be treated very carefully, and they need to get re-evaluated as having refractory epilepsy. So that's very important. But the other side is those patients that have de novo status epilepticus. So there are, of course, various situations which can cause, as an etiology, clear causes that can cause status epilepticus: cerebrovascular diseases, brain tumors, CNS infections. But then there are a lot of situations that are not so evident. And then we have the situation of NOS, new onset refractory status epilepticus, without any clear acute or active structural, toxic or metabolic cause. And this is usually, very often these patients are young, and they need to really have a very thorough workup, especially if the situation turns out to be refractory and or super refractory. So this is again for epilepsy patients. There are also situations for patients with epilepsy where we need to do surgery in an emergency situation, and more this is also done and seen as a sort of a effective way of treating the situation. Sometimes the status epilepticus doesn't cease, or we cannot get it into a control without moving towards surgical intervention, and it's quite doable also from the intensive care unit setting, and should be taken into account as a possible procedure. But coming back to the nose, so within the first 24 hours, with the newly onset refractory status epilepticus, first, of course, we should initiate the status epilepticus protocol. We should treat as we treat very effectively status epilepticus, but at the same time, we should then start to obtain the history. We should start to look whether there are any kind of hints why this is happening, any kind of immunosuppression, medication, supplements, recent illnesses, recent vaccinations, recent traveling, accidental or occupational exposure to animals, insects, pathogens, drugs or toxins. This is quite a workup, and this needs to be done with your colleagues. This is very multidisciplinary work and needs to be done quickly. These instructions have been copied from website of Norse Institute, and they have a very large and detailed checklist for Norse patients, and I would really recommend you to look at it. The website address is attached in this slide, and you can find there very good checklist and protocols for also various geographical areas to work on with. So then we should, of course, image the patient with and without contrast with MRI, and if possible, initiate EEG monitoring, and if possible with video. And then move to different kind of serological and other testings. These next few slides, I have the content I have got from another very good source for you. This is an article that has been published last summer in by Walton et al. Etiological assessment of status epilepticus. So they have divided the screening to several phases, and they have made a huge listing of various things that need to be looked in nose or refractory status epilepticus patients that remain cryptogenic, so that we don't know the etiology after or during the first days of the treatment. So there is a huge list for infectious screening, and they have divided so that there is a list that is recommended for most patients, that the usual suspects, and then there is a list that is recommended for immunocompromised patients, and then there is some tests that is only done if there is there's a geographic or seasonal or occupational risk of exposure. Again, they also recommend this Norse Institute listing for also checkup. Then, of course, we should look at all the autoimmune and paraneoplastic etiologies. And again, there's a very, very good and good listing of the most important antibodies for autoimmune encephalitis and autoimmune epilepsies, and also for antibodies for paraneoplastic situations. They have also advised, very important advice, which is optional, consider storing extra CSF and serum for possible further autoimmune testing in research lab. This is something that we have done several times when we have a young patient where we don't find anything. So we have consulted those laboratories in Europe and in USA that do research and where they try to find new diseases, new autoimmune diseases, and they are very happy to receive these samples, and they also answer clinically. So please also use that possibility. And then there's recommendations for toxicological screening, which is of course very important. There could be toxins and drugs that could cause seizures, and these needs to be screened both from the history, but also from the blood. And then optionally other things are mentioned here. And this is the last slide from this screening list. There's recommendations for metabolic screening and neoplastic screening. Then for the investigations, this is again very important for the paraneoplastic symptoms. So full body CT and PET, depending on the gender, scrotal ultrasound or mammography. And then also CSF should be investigated via cytology and flow cytometry, and pelvic echo or MRI could be also done. Mitochondrial disorders and also inborn error of metabolism screening should be performed. And then last thing is genetic screening, again for mitochondrial diseases, but also whole exome sequencing could be thought. This is the staged approach also with the investigations. So first sort of imaging, CSF screening, infectious screening, autoimmune screening, and toxicological screening to find the most usual suspects, usual situations. And then if it's still unknown etiology, then we should consider the further investigations like oncological screening for inborn error of metabolism and mitochondrial disorders, and perhaps larger genetic screening, especially in children. And for example, in Finland, we are sort of a genetic isolate. We have some diseases that belong to our genetic Finnish disease inheritance. So we usually look for them. So there are situations depending on where you are, what you always need to do first. And of course, the last thing here is also very important, and at least in our clinic, we quite often, in fact, end up also doing and considering brain biopsy, especially if there's at least some findings or any signal intensity changes in MRI that you can biopsy. So moving towards the therapy, there is of course increasing interest in immunological therapy because we have found, first of all, etiologies like autoimmune encephalitis more and more, but also we know that the neuroinflammation plays so important role in epileptogenesis that it might also help in these situations. There is no controlled studies about immunological therapy in superrefractory status epilepticus, and there is no evidence-based treatment guidelines. So everything that we use is based on case reports and also anecdotal evidence only. But currently what we do, we use immunomodulatory therapy with a definite diagnosis of an immunological cause of status, but we use it also, and I emphasize this, we use it after we have taken the screening samples, after we have investigated the patient, we start to use these immunomodulatory therapies also without a diagnosis on immunological cause of status. So, and this is the list of the choices. We can use steroids, we can use IV immunoglobulin, plasma exchange, then rituximab, tocilizumab, anakinra, and some other agents. Again, please look at the North Institute webpage. There is a flowchart of different stages of their suggested treatments, and regarding immunomodulatory therapy, they suggest that first-line immunosuppressive treatment should be either methylprednisolone IV, IVIG, or then plasma exchange. And if there's no response, then they move to either rituximab, tocilizumab, anakinra, ketogenic diet, cyclophosphamide, or some other treatments. Rituximab and tocilizumab are sometimes used instead of each other, mostly so that many centers first start rituximab, which is a B-cell drug, and then if the situation is rituximab resistant, then tocilizumab, which is a T-cell engaging drug, is used, and at least we have had some favorable results with this approach. Rituximab is somewhat more widely used, at least so far, but it might change this situation also. Some other treatment options is here. Neuromodulation, VNS, has been used to a certain extent, and this is a case report from Finland, from Tampere, by Jukka Peltola's group, where they successfully managed one patient with anterior thalamic deep brain stimulation, and the results were surprisingly favorable. And to my knowledge, there are a couple of other similar experiences so far worldwide. So perhaps neuromodulation is going to be more and more used in future for also these indications. Hypothermia potentially could be neuroprotective, and therefore there has been a lot of discussion during years of using it. So far the results have not shown neuroprotection, but there has been encouraging data regarding anticonvulsant activity, so the seizures have reacted favorably with a small series of hypothermia. And same is also true with ketogenic diet, and that has been also increasingly being used for refractory and super-refractory status epilepticus. There is data that this might be especially suitable for those patients that have a myoclonic status epilepticus and for many syndromes like electric convulsive status epilepticus and different kind of epileptic encephalopathies. And it's of course quite easy to start, for example, in the ICU. So therefore, it should be perhaps used more, and it might allow, again, sort of background treatment, and could be used as a sort of underlying treatment for short periods and sort of to bridge other therapies. But more data should also be available soon for ketogenic diet in various status epilepticus situations. Then a group of treatments that is at the moment really of intense interest is neurosteroids, and this comes back to the trafficking problem. So these positive allosteric modulators also influence at extrasynaptic kappa A receptors, and therefore these extrasynaptic kappa A receptors are not internalized, and therefore this might resolve the benzodiazepine resistant problem in prolonged status epilepticus. And one of the first neurosteroid that was investigated was allopregnanolone, which is an endogenous chemical. And there was very striking positive case reports showing remarkable efficacy in the beginning, and therefore FDA gave an orphan drug indication to it as in status epilepticus and fast track designation. And there was a phase 2 open study of 25 patients that showed control in 77%, again, very positive results. But then randomized control trial of 150 patients reported no effect. So the idea was that as benzos only act at the synaptic kappa A alpha 1 receptor, this allosteric modulator allopregnanolone would then act at the extrasynaptic kappa A receptor and would act also during the refractory phase of the status epilepticus. And therefore the trial was started. There was placebo-controlled trial, and primary efficacy endpoint was continued resolution of status epilepticus for 24 hours following wean of third-line agents. The results are in the bottom of this slide. So primary outcome was achieved in 29 patients out of 66 patients, so 44% in the allopregnanolone group and 42% in the placebo group. So they didn't differ at all, which was really a disappointment. So the trial didn't achieve statistical significance, but the problem probably was that this was too complicated protocol, and there was so much learning in the protocol. There were many centers, 100 centers that had to learn how to wean an anesthetic and then start this trial. And not all the centers even had continuous EEG at the site. There was a lot of learning points in this during this trial, and it's really sad that this trial has not been published, because I think we learned a lot of things, including the many learning points from weaning of the anesthetics, and we harmonized a lot of things that were not done earlier. And therefore, these detailed experiences from this trial should be published to increase our knowledge. The patients were also very seriously ill, and people probably took very super refractory patients into this trial, and nothing would have really helped the patients. And therefore also the placebo helped as much as the active treatment. But in any case, it really increased our knowledge, this trial, and what is also very important, it showed that status epilepticus trials also in super refractory patients can be done. What is now happening in this field is that Marinus is having synthetic analog of allopregnanolone canaloxone, which they are investigating in several genetic epilepsies like CDKL5 deficiency disorder, where they in fact got a positive result just a couple of weeks ago, and other epilepsies, and also in tuberous sclerosis complex. And they are also now looking at status epilepticus. And they are starting at the moment already phase 3 study, and they are using canaxolone in an earlier phase. So a target population is status epilepticus patients who have failed benzodiazepines and 2 or more IV anti-epileptic drugs, but these are just entering to the refractory phase, and they try to prevent the anesthetic use by using canaxolone. So this is now an earlier phase than the SARS or the allopregnanolone trial, and let's see whether the primary endpoint is then achieved. So the primary endpoint is going to be how to prevent the anesthesia, and it's going to be very interesting to see. But if this succeeds, then we have a new drug for also refractory status epilepticus. So regarding the first 24 hours, pitfalls, there are some pitfalls leading to sort of pseudo status refractory, super refractory status epilepticus. So of course, if there are delays during first and second stage, this can really mean that we get super refractory status epilepticus. And unfortunately also, for example, in our center where we are really very active, it might take hours to get the patient to the anesthetics and to the ICU, and therefore this lost time means that we really then end up unnecessarily to having super refractory status epilepticus. Then, as I said, sometimes we are not ensuring adequate background anti-seizure medication during weaning of the anesthesia, and therefore we end up having back the anesthetics and therefore we have super-refractory status epilepticus. Sometimes we are not also using adequate depth of the first anesthesia, and therefore we end up having a second or third anesthesia, and therefore we are having super-refractory status epilepticus. Then we might not look, or we might not find the treatable etiology, and therefore we prolong the status epilepticus. And then one very important issue is also that we might overinterpret the EEG during weaning of the anesthesia instead of observing for more definite clinical or electrographic results. So there's here I mention also one article by Alvin Das and group who show that there might be this kind of ictal interictal EEG patterns that you should still look and wait and observe a little bit longer and not start a new anesthesia. And you shouldn't not overinterpret the EEG findings. So these are very important sort of pitfalls that can lead to pseudo super-refractory status epilepticus. So then coming to the palliative side of the refractory status epilepticus. So not all the patients need to be treated or should be treated at the ICU, and this needs to be decided. So palliative care, of course, means that we still improve the quality of life of the patient, although we are not treating to cure the patient, and we are providing relief from the symptoms, and this should be always also in mind that this is one of the options also for the status epilepticus patients. There's a term futility, and it comes from the Greek mythology, where these ladies, Dianades, were eternally filling an unfillable vessel to atone for their sins. And this could relate for our situation as doctors and nurses caring for extremely ill patients with the feeling of carrying water in a leaky bucket and continuously working towards a goal that could not be achieved. What medical futility at intensive care unit means, sometimes there's a condition when a patient receives treatment that so futile intensive care is defined that interventions that prolong life without achieving effect that the patient can appreciate as benefit. So there is no corresponding benefit to the patient, and this needs to be thought. As I said, there is difficulty in predicting this, especially in status epilepticus. But in general, the severity of the illness, age, and especially overall frailty and functional status before hospital admission, and of course presence of comorbidities are very strong predictive factors that the intensive care it might be futile for the patient. What is also important to understand that it's not so that if we enter the patient to the intensive care unit, we should continue the treatment forever in the intensive care unit. There's also an idea of a time-limited trial, and it's very important that we should define the intention of the status epilepticus treatment and the goals of the care with the family and with the surrogate decision makers early in the patient presentation. So we should start to think about whether this is a very actively treating patients, whether there's a palliative treatment, and also along the line of the treatment and along the process, we should think whether we are continuing the treatment, and we should set the targets or time limits and targets for example, for the next anesthesia and for the trial in advance. And if the goals are not met by the allocated time, then the treatment should be withdrawn according to the plan. Why this is so difficult? We doctors and medical personnel, we have a different kind of view of the, for example, for the cardiopulmonary resuscitation than our patients and the family members very often have. And of course, they cannot know it, but there's also a problems because, for example, what they know about resuscitation, for example, it comes from television. And this is a very nice example of what is known about then intensive care unit treatment or, for example, resuscitation. It comes from the television series or television dramas very often. And this was really a study where they looked at 26 episodes of Casualty, 25 episodes of Holby City, 23 episodes of Grey's Anatomy, and 14 episodes of ER, very famous television series and dramas. And they don't give a very realistic view of CPR. Usually they may give a falsely high expectation to the lay public. And therefore, if you discuss with the patients and with their family members, you need to be aware that there are these kind of potential influences relating to the experience from, for example, of viewing these television drama. And I think I also noticed it when COVID-19 situation and started in my country. There were people who really sort of thought that when you just go to the intensive care unit, you come healthier back to your home than you used to be, so that it sort of cures you totally. And that's not true. It's a very dangerous way of treating, and usually there are a lot of complications, and that needs to be explained to the family members. So coming back to the palliative treatment, so we should, of course, palliatively also treat with the first line treatment. We should use all the second line treatments. The problem in palliative treatment is that it's not always possible to use the intravenous routes. And if it's not possible, then sometimes we can off-labelly use also subcutaneous or routes with these drugs. So phenobarbital, carbamazepine, valproate, lamotrigine, and levetiracetam can be given rectally, and some drugs can be given subcutaneously. But all these routes are anecdotal and off-label. But if needed, they can be also used like this. But of course, IV, second-line IV treatment should be also available for palliative patients. But then when we need to continue the anti-epileptic drug treatment after status epilepticus, then of course there are oral liquids via nasogastric or PEG tube. And if really the patient needs the medication, I would recommend that then you should move to intravenous treatment, because that's usually possible via vascular access. If the patient is risk for status epilepticus, then IV formulations are the ones that really give the protection. And if oral use is not possible, that's then very important to also remember that rectal or subcutaneous use is not really the best way of using these drugs. They are really off-label and not guarantee the levels that we really need to prevent the seizures. And it's very important to understand that seizures also should be treated with the same level of importance as pain or anxiety in the palliative patients. And then, as said, coming to the third stage, one-time time-limited anesthesia can be offered also in selected cases in palliative care if the situation is refractory. But mostly, I think what we should use in these cases is palliative sedation, which is then means that it induces a state of decreased awareness by administration of sedative medications, usually midazolam or propofol. It alleviates the symptoms or even sometimes epileptic activity, but usually epileptic activity persists and we don't need ICU for this. So this is the protocol and the stage protocol for management of status epilepticus in palliative situations. So in selected cases for refractory status epilepticus, you could do one trial of propofol or midazolam anesthesia at ICU, but usually it's palliative sedation. And for super refractory status epilepticus, the treatment is palliative sedation. And these are my conclusions for the whole talk, both for active and palliative care. I would recommend that you evaluate early whether the patient is in active or in palliative care. And for active new onset refractory status epilepticus, these patients should be investigated and treated very early and actively. And there are now available many protocols that you can check that you're not forgetting anything. These are so overwhelming, as I showed you, that we all need to have these checklists, and nobody can anymore remember these things, and they are also updated continuously. So that we need to all check the latest information from the updated lists. We need to also try to treat the etiology when it's possible, and we need to remember to prevent the recurrence with the background anti-seizure medication, so build up the background medication. We need to work with our colleagues, so that we need a multidisciplinary approach. This is not only neurology, this is work up with many colleagues. And luckily now, COVID has also helped us in that respect, that I think it's, at least in our country, it's now easier to get people to discuss in like in Teams or in other remote video meetings, also about patients. And we have had excellent discussions about also status epilepticus patients lately. Very effective, in a very effective way. And then there are these predictive factors and variables like old age, high severity of acute illness, overall frailty, poor functional status before the status epilepticus, and presence of severe comorbidities. that increase the probability of poor outcome, and then unlimited ICU treatment in these palliative patients is not indicated. It could be even futile and harmful for these patients. The current predictive tools have limited value, and I hope that you, as young people, you find better ways and use the big data and machine learning models that would allow us to integrate all the huge amount of data that we have, the clinical, genetic, metabolic, inflammatory, structural biomarkers, and then that would allow us more accurate and personalized prognosis for our patients. Thank you very much. Thank you for your attention.
Thank you very much. Thank you, Professor Kälviäinen. We have a few questions from our audience on the chat. I think that you probably already answered some of those during the talk. I'm going to read them through.
Okay.
First question is in regards to non-convulsive seizures in ITU. My understanding is that the question is referring to whether refractory and super-refractory non-convulsive status epilepticus is treatable. What is the prognosis?
Well, we should separate the comatose non-convulsive status from the situation where the consciousness is preserved, and those situations are totally different, and if the patient is in the ICU, usually the patient is always comatose, or at least there are then usually medications are used that makes the patient makes the consciousness decreased, and therefore it's also difficult to evaluate the consciousness. So at the ICU we need EEG to evaluate the first of all the situation. I'm not quite getting the what is the aim of the question, because there is not anything particular whether the patient is at the ICU and having non-convulsive status. Usually that's most often that is a situation where it should be treated, seeked, sort of diagnosed and treated actively, and according to the principles that I showed. And then there are other factors that then decide that on the basis of which we should decide whether we don't treat it or not. But I probably didn't get what was the aim of the question.
Yes, I apologize. I asked for clarification. This was my understanding of the question. Thank you very much for your answer. The next question is, what do you think of the combination of ketamine and midazolam in refractory status epilepticus and super-refractory status epilepticus? And when would you start down titration? Which one of the two should be removed first?
Well, they are very often used together. That's true. The problem of midazolam is, of course, that what we were discussing, that benzodiazepines, the patient is very often resistant to benzodiazepines already at that point when we are now in refractory or super refractory states. So we often need to use a lot of midazolam, and the efficacy of midazolam might be relative, but still it can be used, and they are then they have both different mechanism of action. They support each other, and we also use them together, and then we withdraw ketamine first. And but problem is that because of this receptor trafficking, there might be sort of a lack of efficacy of midazolam, and I hope that we would find some other combinations to ketamine which would work better, and there are some ideas that probably will be better than midazolam, which is used at the moment.
Thank you very much. The next question is in regards to centers. Do you know which centers can help with CSF fluid screening if we suspect an autoimmune condition? I suspect this refers to international centers which can accept CSF.
Well, during the last times we have sent our samples to Oxford, and then of course Professor Dalmau also has been active in so these two centers, Oxford and Professor Dalmau's laboratory, have been those who have been really active, but there are others also. So you could seek them from the articles, and those laboratories that are active in research of autoimmune antibodies and encephalitis, especially also in epilepsy. They of course want to also find out new situations where they could find new antibodies, and they usually want to have a very short description of the clinical features and clinical setting, and then you can send the CSF and serum samples there, and at least we have got quite quickly the answer that they don't find at the moment anything, but then they can later on inform us if there's something new with the investigational studies that they are performing. Of course, this takes some extra effort, but sometimes it's really important to try to also, for the patient's sake, it's important to try to be active in this way. And this is the way that we are moving forward. We are really finding new. This is the way that all these autoimmune encephalitis they have been found by collaborating internationally.
Thank you. That's really helpful. The next question is again in regards to the autoimmune encephalitis antibodies. So the question is, when we are checking for the antibodies in refractory status epilepticus, should we better measure the antibodies in CSF or in plasma? What would be your recommendation?
Definitely, you should always have both samples at the same time, and before you start the immunomodulatory treatments. So try to get these samples and CSF especially. Plasma or serum is not enough only. So CSF, you need to get a CSF sample if you want to be sure that you don't have any autoimmune encephalitis, and then the paired sample with the serum is the best. And usually we take several samples, but the best, of course, is the one or ones that are taken before any kind of immunomodulatory treatment is given. So from those samples, you should take the extra tubes. So please observe still be able to get the extra tubes from those before the immunomodulatory treatments.
Thank you very much. The next question is in regards to transcranial magnetic stimulation in superrefractory status epilepticus. Is there any protocol or experience with this?
I know that there have been some cases that have been treated in my clinic, where we are very active with transcranial magnetic stimulation in other, mostly in diagnostics and also in treatment in psychiatric indications. We haven't started to use it. There has been a plan that with the removable equipment we would do it, but we haven't planned any protocol. So I cannot give any detailed protocol or answer to that. I'm not aware of any protocol that we would have, I would have seen or we would have discussed in detail. And during the last sort of years, or it has not been so much upfront than earlier. There was a lot of enthusiasm, but I think it has sort of decreased for some reason. So I'm at the moment, although we are quite active in transcranial magnetic stimulation in Kuopio, for example, it's not something that I would see as the most prominent treatments in future.
Thank you. The next question is a question about management. I will read it to you. If one patient develops nausea and with IVIG and corticosteroids hasn't regained normal consciousness and her non-convulsive state of epilepticus continues, what is your next treatment option?
So could you repeat what would have been used already? So it was
IVIG and corticosteroids
were used. So then and there were no antibodies.
It's not specified actually.
Not specified, yeah. Well, in any case, superrefractory status epilepticus. What we usually do, we start rituximab. So, for example, just recently we had a nurse patient with no antibodies, no etiology whatsoever, and signal intensity increased widely in MRI. And we did a brain biopsy, which was normal. But before getting, of course, that result, and before getting the antibody results, we started rituximab. And if the rituximab wouldn't have worked, we would have then switched to tocilizumab, which I have seen also. It has really worked in some of the cases where rituximab has not worked, then especially in those patients that have changes in MRI. This case that I just now described, there was a situation where probably the signal intensity was not due to autoimmune encephalitis, and although it's first seemed that there was an excellent response to rituximab, in fact, probably what happened was that the ketamine and the proper anesthetics with proper doses and proper background anti-epileptics helped, and it was not rituximab, because the signal intensities vanished and the MRI normalized very rapidly. So probably it was vasogenic and cytogenic edema only. But it might be also that together anesthetics, anti-epileptic drugs, and rituximab worked, and therefore, although we don't have any, like in this case, any antibodies, we don't have anything than that probably this was a newly onset epilepsy, which started with status epilepticus. I would still use these immunomodulatory treatments also very actively nowadays in these NOS patients.
Thank you very much. That's very interesting, very helpful to hear from your own experience. We still have 4 more questions. There's been a lot of engagement from people watching the webinar. Are you still happy to go? Because I know it's quite late in Finland.
It's yes. Well, let's take one question still. Yeah.
You covered about suggestions regarding palliative care, so I will skip that one. And the next one was, you mentioned 100 centers involved in one study. Are there any plans in Europe to form a network of centers that could be streamlined to conduct future studies? How can we get involved?
That's a good one. Yeah.
From Ireland, I think, if I'm not.
Yeah. So what I think at the moment, how we should streamline it is perhaps via EpiCare, which is the European reference network for rare and complex epilepsies, where we are member center, where there are at the moment 24 member centers which treat, as said, difficult epilepsies, complex epilepsies, and rare epilepsies, genetic epilepsies, and other rare complex epilepsies, which is also status epilepticus is a rare and complex epilepsy, and this is activity run by European Union, so European Commission, and but then we could also, of course, include other countries, but this could be the core organization that could then start building this kind of activity. But it's true that with that kind of organization that the SARS trial had, they had 2 huge challenges to do when they at the same time started to build up their own trial, and they started to build up the consortium or the 100 centers community, which started to learn how to do trials in super refractory status epilepticus. So what we should do, of course, we should build up this kind of consortia that really within our research network also create the knowledge and to do these trials, which are really extremely demanding, but they are also very much needed.
Thank you very much. There has been a special request. More people are asking one specific question.
Okay, let's take it.
Your time. If you're happy to answer it.
Yes. Yeah.
It is a question of quite a few people watching. The question is, in centers without continuous EEG, what would you suggest for a reasonable approach to EEG for a patient who has just been taken to ICU after a convulsive status epilepticus event?
So there is no continuous EEG, but there is any EEG?
Yes, I suspect there is a routine EEG, but not a continuous EEG.
Yeah. So of course we have had that kind of situation also in Finland, and there are. I should have perhaps mentioned that. So we shouldn't treat the EEG, of course, if that shouldn't prevent us from treating patient if we don't have EEG, and of course then we should of course always treat what is clinically seen and clinically obvious. But then if there is EEG, as we usually still have, and then what is very often important is that you should time your efforts, your weaning, and your decision making when you are able to get the EEG. So you should do the EEG recordings and try to estimate what you and make your decisions on basis of EEG also. So it's a little bit difficult now to so of course also we don't usually look the EEG continuously. It might give a false impression that somebody is looking the EEG continuously. So there is the continuous EEG, but it's not evaluated continuously. So therefore, first of all, try to aim towards having continuous EEG, but evaluating it regularly, but not continuously. And then if that's not possible, then doing EEG on daily basis and evaluating what is possible on the basis of that. I'm not sure whether this and especially if there is no emergency EEG, then patients should still be treated, and it's not so that the lack of EEG or emergency EEG prevents from treating, and also anesthetics can be used also without EEG. So it's important to treat these patients. I'm not sure whether I answered this. Do you want to still ask more about this?
So I think you have answered, and thank you very much. Thank you very much for an excellent talk, very comprehensive and very engaging. It was really appreciated. Thank you very much, Professor Kälviäinen.
Thank you for all your time. It was my pleasure. I really like this ILAE activity and also this program of these talks. Thank you very much. This is now nearly midnight, so I'm going to go to sleep now.
Thank you very much for your time. Thank you.
Yeah, thank you. Bye bye.
Bye bye.